Hello, everyone. It's Dr. Nyla, and welcome to week number 6. As always, I'll try to keep this lecture pretty short and just highlight some things that I think are very important for your learning information. When it comes to your abdomen, there are certain things that I do want to make sure that you have very good knowledge of. So we'll start with abdominal pain. Always remember that common things occur commonly. So, as with any condition, make sure you know what your top differentials are, how to rule those differentials out. You should be able to perform a focused physical exam along with specific maneuvers, especially when it comes to abdominal pain. So you should know what rebound tenderness is. You should know what a psoas sign is. Be prepared to recall that information in your clinical settings and also on examinations. And you should also know about the appropriate diagnostic testing for each condition that you're trying to rule out. So it's not okay just to order a test. You have to know why you're ordering that test and what to do with those abnormal findings if you have them. The first condition that we'll look at is appendicitis. The hallmark symptom of appendicitis is right lower quadrant pain. If you see right lower quadrant pain on a board exam, if you see it in your clinical practice, the first thing you should think about is appendicitis. That should always be on your differential list. Additional findings with that can be that the patient may experience some anorexia, they may have some fever, they may have nausea or vomiting. Sometimes patients will present with the pain in different areas, so it may start off in the epigastric region, it could also be in the periumbilical region, but eventually that pain typically will migrate to the right lower quadrant. The patient may also have some abdominal rigidity, so think about peritonitis, but please, always, with right lower quadrant pain, think about appendicitis. Another potential cause of an acute abdomen could be a small bowel obstruction. This is also something that I expect that you guys would be able to pull into your differential list. These patients may complain of some intermittent cramping. They could have some vomiting. There could be hyperactive and also the high-pitched bowel sounds. If you hear those high-pitched bowel sounds, that can be indicative of an early obstruction. And you'll also see the word obstipation in your notes, which is just a prolonged retention of dry feces. So if you see those, think about small bowel obstruction. And with the small bowel obstruction, the pain can be relieved sometimes by vomiting. So if the patient say, I'm having this really bad pain and it gets better when I puke, make sure that small bowel obstruction is on your differential list. The next condition I want you guys to take a look at is a ruptured aortic aneurysm. It is actually one of the leading causes of death in the United States. The thing that's so scary about the ruptured aneurysm is that it may or it may not have any symptoms. Some patients may experience some flank pain, some groin pain, or some back pain, but for some, they're completely asymptomatic before the rupture. Other common conditions to think about are perforated peptic ulcers and peritonitis. So make sure you have an awareness of their presenting symptoms, what could potentially trigger these, and how you would manage that. I mentioned this briefly before, but make sure you know the special abdominal maneuvers, know how to perform them, and know if they're positive, what does that indicate? So it's not just enough to know how to do the test, you got to know what the test means. Differentialists are important. It is extremely important that you have a vast list of differentials that you can quickly run through in your head when you are seeing your patients. This is just an example of potential differentials for patients that present with abdominal pain. The management of an abdominal condition will be based on your diagnosis. It will also include how you get to your final diagnosis. So things such as performing a complete physical and getting a really good medical history are paramount to you getting to the proper diagnosis and the proper treatment plan. Again, it is important that you know what test to order. You should also know when it is time to refer. Is it time to refer to the ED? Is it time to send them to GI? Is this a surgical consult? These are things that, as an advanced practice provider, you will be in the decision-making seat, so you need to know what the next steps are for the patient. And please, don't miss an acute abdomen. And now we'll move on to constipation. Constipation can be highly subjective. It is actually highly subjective. So when patients come in and tell you that they are constipated, every person will have a different definition of constipation. For your purposes of testing and documentation, we need to have something that we can objectively record as constipation. So if patients are having fewer than 3 bowel movements per week, if they're having hard or lumpy stools, if they're straining, or they feel like they haven't had a complete bowel movement, like there is still something there that needs to be evacuated, we can use that as a definition of constipation. I would be remiss if I didn't mention red flags. Red flags are red flags for a reason. You should not miss these ever. If a patient has sudden change in their bowel movement, that's a red flag. If suddenly they've lost 10 pounds or more and they can't explain this, they're not on some special diet, that is a huge red flag. Patients that are having blood in their stools or they're suddenly anemic, those are also red flags. And if you see sudden changes in a person over the age of 50, that is also a red flag. So these are things that you should not miss under any circumstances. When it comes to the management of constipation, you will need to perform a complete history. You'll need to know what tests to order if you need to order tests. You need to know when to refer, and it is also your job to know how to treat constipation. If you notice, I'm intentionally not including treatments in these lectures. That's because I want you guys to go and look those up. I find that when students look things up themselves, it sticks better and you'll be able to commit it to memory much better than if I just give it to you. So make sure you know treatment plan for constipation. Diarrhea is next. Like the roll of toilet paper, if you got diarrhea, if you've ever had diarrhea, you'll need a lot of toilet paper. Diarrhea can also be highly subjective. So patients will tell you they have diarrhea. You will need to be able to document that. So for your purposes, the definition of diarrhea is when there is an increase in stool frequency and there are more than 3 stools per day. The stool should be loose or liquidy. They shouldn't just be like a little soft. And there is an acute phase of diarrhea. That's when it lasts less than 2 weeks. And then we get into chronic diarrhea where it lasts a month or more. The management of diarrhea is something that you will need to look up. And you need to know when to refer your patients. When they have diarrhea, you should know your red flags. Know the difference between like a viral case of diarrhea or bacterial. So think about stuff like traveler's diarrhea. How would you manage that? And identify the possible triggers for the patient's diarrhea. Sometimes there are underlying conditions beyond something like traveler's diarrhea that could cause the patient to have recurrent diarrhea. Next, we'll talk about GERD. If you've ever had GERD, this is exactly what it feels like. I've had it before. It's terrible. Here is a working definition of GERD. Basically, what's happening is the stomach contents are working their way up into the esophagus and causing some irritation. The most common symptom that patients will present with is saying they have heartburn. Other patients will complain of bitter burps. Some patients will develop a cough. There can also be non-cardiac chest pain for people that have GERD. And make sure you know those red flags. I believe I've added this to your supplemental learning this week. But the management of GERD is lifestyle modification. So, lifestyle modification could be consuming less caffeine, avoiding NSAIDs, not eating right before bed. Medicines that may be given, we can do H2s, we can do PPIs. Important to know, again, when do you refer? Okay. And things such as weight loss, voice changes, difficulty swallowing, those are red flags. Don't miss it. And in conclusion, if you have not learned anything else from this lecture, I hope that I have instilled the importance of developing a differential list. You need to know when to refer, and you have to know those specialized abdominal maneuvers. Those things are going to carry you throughout your clinical practice. If you do those special maneuvers and you get a positive test, you need to know what it indicates. And then finally, the red flags. Under no circumstances should you miss the red flags. And here are my references. They are shared with you guys in your supplemental learning in the course. You'll be able to access those references if you need them. And that's it. Good luck.